So we'll skip through a lot of this talk, but just to get to some of the costs, and just to add a little bit to the discussion, I'd say, uniportal, VATS, RATS, the most compelling thing to me is that view of the posterior hilum that Dr. Lazaro showed. And Diego, I know obviously you're a strong believer in the uniportal. Is there a restriction, I'll ask you to maybe answer this later, in still restricting yourself essentially to a single view, and versus the freedom of the entire chest as a view, posterior, anterior, superior, inferior, at any point where you want to go? Clearly the operation can be done, it can be done very well, and it can be done in a standardized fashion. But that would be the question I have certainly for these different approaches, and simply having better views of the entire chest. For me, that's the most compelling reason for robotic, potentially, versus uniportal. But there's no doubt, seeing your videos, seeing your technique, I myself am drawn to it, feel that it's something that has to be explored very closely, and certainly is going to be part of the future. Again, let's skip most through all of this. I'm going to take us straight to a little bit of the outcomes. I think you've heard enough about outcomes from Dr. Christie, Dr. Lazaro, and regarding now, I will say one caveat here. Whenever we're adopting a new technology, it is important to look at outcomes and to be very honest with your outcomes. Here's an experience in our first 250 lobe from 2014 from Memorial, where we noticed an increase in chylothoraces and recurrent laryngeal nerve injuries in the robotic cases. Now, you could say also it was two younger surgeons that were potentially building and working through their learning curve, but this was also independently verified by other very experienced surgeons, Dr. Cerfolio, that these complications were independently correlated with robotic approaches. When we looked at them very closely, it's a very extensive, and it's an oxymoron. We're having a incredibly magnified view of the field with better dexterity, potentially doing an over-skeletonization of the right paratracheal space. As soon as we backed off on these dissections, we saw a decrease in these complications and obliterated these complications. But you have to understand the complications with any new technology. Look at them honestly. If they can't be corrected, you have to ask yourself the question of whether this is really an improvement for the patient or not. We don't want to do the approach just for the sake of the technology. We've heard enough about the learning curve. We've heard about costs. So this is one of the studies that was brought up, the Swanson study, looking at one of the large premier databases, showing that VATS robotically had higher costs. This is in an early time. I would say that that's when we were really just building our experience with robotic VATS. This is the Michael Kent, who's actually an alum of this program, experienced as well. I'm going to move past that. And here, I'd say, is one of the more compelling things I've seen recently. This is Bernie Park's most recent experience out of Memorial Sloan Kettering, now looking at propensity matched cases, robotic versus VATS versus open. And one of the few experiences now suggesting that robotics has significantly improved oncologic outcomes. You have to take it with a big grain of salt. This is a retrospective study, propensity match as best as we can look at it, but improved 5-year disease-free survival versus VATS. What's the reason? Don't know. And this would have to be confirmed and prospective, but something to think about. We do see that in some other minimally invasive experiences as well. And then an experience from Dr. Cerfolio looking specifically at costs of these procedures. Median reimbursement for these patients is about $18,000. Immediate profit margin for specifically just the robotic cases is $3,500 on a thoracic service for lobectomy. This brings up a very important point regarding robotics and costs for institutions at a place like UPMC, at Northwell. Other large institutions that are using robotics across multiple services, the amortized cost of the robot decreases significantly as long as the case mix index of the cases being done remains relatively high. Thoracic surgery, surgical oncology, these at this time are the profitable service lines for robotics. So we are very lucky to be in thoracic surgery in a surface line that is showing a positive margin for the hospital. In many large institutions, this is unfortunately not true for gynecology. It is not true for urology, and the overall margin is decreasing or negative on those service lines. So it is thoracic surgery, it is surgical oncology that is at least causing a positive margin on the robot, and it's getting better. Is it better versus VATS? Well, that remains to be seen. This is our data, an initial premier data after 71 cases at UPMC, in which, without going through the busyness of this slide here, this is based on comparison to national insurance data. Versus open, we're certainly doing better with our robotic cases by a margin of about $4,000. So a robotic case has a margin about $4,000 better than our open cases. Interestingly, we're seeing a margin versus VATS positive also. $720, not a very significant number when it comes to OR costs, but still positive versus our VATS cases. A recent propensity match study that we just completed, and I have to give Garrett Coyne a lot of credit here, one of our residents in the lab who really went through and completed this study over a 2-year period, looking at 74 propensity matched pairs. This is out of 86 initial robotic cases, lobectomies and segmentectomies, all anatomic resections done within the first 2 to 3 years of inception of the program. And this is now the total number of surgeons performing is about 2 to 3. Started with myself, and then as we onboarded more people. So it's not just a single surgeon experience, but yes, it's with an experienced person coming and building the program. Regardless, the comparison here is showing that we have actually decreased operative times. Now there's a lot of caveats here. We're not going to delve into the exact details of this study, but estimated blood loss, OR time decreased, lymph node counts approaching greater, chest tube days less on the robotic cases, air leak is less on these cases, but not significantly. And interestingly, costs are significantly less with the robotic cases. A lot of caveats behind that, a lot of it having to do with, as Dr. Christie mentioned, pathways that we use for these patients. But and this is activity-based costing, one of the best costing analyses you can do. This is with the data coming directly from our financial people at the UPMC Steel Tower, showing that the direct costs in the hour and the OR themselves are not significantly different, if not less for the robotic cases, and that the overall costs are decreased for the robotic cases at this institution for these propensity matched cases. So again, big grain of salt to be taken with this data, but we're certainly not doing worse than the VATS cases, and we may actually have a higher profit margin while maintaining excellent outcomes for the patients. So that's really what I wanted to just say a little bit about the costs here. Otherwise, you've seen some excellent outcomes and really examples of cases from the previous speakers. So technologies that come with these platforms are going to improve. This is simple stapling. Now stapling under the control of the operator themselves. Again, as Dr. Lazaro mentioned, just putting the control of these operations into the operator's hands. Now, some of these videos don't seem to be playing with the new setup here. And I think that's probably the problem you have. We'll have to investigate that after this session. But this is ICG, which you would have seen growing green in the sentinel lymph node here. So I'm not going to bother trying to show the videos. They're clearly not working at this point. I'm going to show a little bit about mediastinal lymph node dissection at a later session. And again, a lot of new technology coming out, advanced tumor localization, different ways to image using this large computer that sits between you and the patient. And I think that will stop and take some questions for the speakers as well. All right, thank you. I'll have the speakers come up again if you guys don't mind. And Diego, potentially you as well. You may as well come up and field some questions, and we're going to take a break. How many, just to take a brief survey, how many surgeons here are doing robotic cases? 1. We've got 1, 2, 3, 4. How many are doing VATS? And how many uniportal? I thought I saw the cameraman raising his hand. But I think Rodney's not in the room. Dr. Lander now, I believe, is performing uniportal cases at this point. So I guess question, if for any of the panelists here, again, the same sort of similar question, if you could, how much do costs, I would say just cost-wise, Diego, clearly I think your approach has the clearest potential benefit for cost. Do you have an idea about the cost for your cases versus robotics, or has that been looked at?
Well, it depends It depends where I do the surgery. If I want to save money, I can be very cheap because I can tie the vessels. For example, in some countries, or in some parts of China, I used to tie the vessels just to save money. It could be really, really cheap. It could be very, very cheap. But it's not easy to tie the vessels doing VATS. So if you want to be cheap, I think Uniportal is probably the cheapest. You save in trocars. You don't need trocars.
Well, I have one question, actually, the operative time factors in. Is this is a faster operation, it's cheaper over our time, but if you're at a teaching institution, for me, the operative time isn't necessarily, the main objective, because it's can be counterproductive to our, training program. So I don't know what you think about that or how that factors in.
I agree. I think that definitely factors in. We're training on every one of the robotic cases as well.
Yeah.
It's hard to know, and I don't place much substance in OR time as it factors in purely for cost because we have a cost per minute in the OR. At a teaching institution, I think should not be the focus of a training program, and you take the time in the OR to teach as long as it takes. And we shouldn't be, I think, one of the papers by Dr. Cerfolio talked about codifying the different steps of the operation and how we teach residents and how we bring them through the learning curve. And what we were talking about this a little bit earlier, one of the points of that paper was that we can measure, or one of the metrics used is how long did the resident take to do that part of the operation. And I actually wrote the editorial for that paper. My main critique was that I'm not sure that's the best metric to measure a resident by. It's the quality of their work, how they progress, and the pressure of time may be the last thing you want to put on a resident or a trainee, or even myself as I'm learning new procedures.
I think, also the time aspect is comparing robot to VATS. It's a different generation. Like the data is 20 years into the VATS experience. And so they're taking really sort of early adopters of robotics and comparing them to a more mature VATS group in addition. So the time number's hard. But clearly we were talking about time earlier. It's really outcomes based. And that's surgeon driven. And really the future is, in my mind, I want to be good in 10 years, but I want to be better in 10 years. And I think no matter where you and I are, we should be able to give the same quality operation that you can only get with data that's recordable, that can be coded, that can be utilized to make a safer instrument, so that the new trainees who come out, as good as they are, get put into a structured mentorship, and then all of a sudden that graduate on day one can execute your operation and you've got 20 to 30 years of experience. Like that to me is the power of the robot. And I can't imagine that we're going to even be having this debate in the future. I really do think it's going to be all uniportal. What do you think, gentlemen?
Yeah, well, as I said, I've been around long enough that I've seen evolution from open thoracotomy to VATS, and I think the robot is probably going to evolve, and I think it's definitely here to stay.
Do you like using it, by the way?
I do like it. I mean, it's, as I said, it's easier to do what you've been doing, but and again, I think it's going to be a different transition for our trainees that have come through, say they've done general surgery, they're familiar with the robot, and they're learning how to do lung surgery. I find, in fact, with the trainees that I find it's easier for them to do the robotic surgery than doing the VATS surgery. I think it's technically a little bit easier. From my perspective, having developed the VATS surgery and never done a robotic surgery for anything, it's a bit of a tough transition. It has evolved a little bit. The angles are different. And I first tried with NetShoe to just try and do what I had been doing with my VATS, and I realized it's not the same. You have to evolve. It's all slightly different. But I think even how I do the open lobectomy has evolved a little bit since doing the VATS, because I do a different technique coming from the front to the back. So I think it gives you a lot more versatility, and it's a bit painful, but it's coming along.
There you go.
Yeah, well, two things. One is about, I'm sure that everything depends on the evolution and competition, because with more competition, more companies producing robots, the cost will be less. and it's like the mobile phones. If we look back and we see how the first mobile phones 20 years ago were like big devices, very, very expensive. Nowadays, you can control the world through a small smartphone, and it could be very, very cheap. So this is the same. I mean, with the robots, will be the same. Now there's no competition. Just one company has all the market. So the cost is high. They don't need to evolve so quick because they have all the market. But as soon as more companies will be on the market with more competition, the price will be less, more technology, more evolution. So I think will be a standard, and the cost will be very, very low. In relation to the training of uniportal VATs, well, I spend a lot of time training people. And when I train residents, I spend a lot of time with them in the OR because I cannot say that it's an easy technique to learn. Of course not. But if you spend enough time and if you follow the steps, how to teach them, you need time. You cannot learn a technique in 1 week. You can learn easily the uniportal because all of our residents, all of our fellows, after being several months with us, they go back to their countries and they start uniportal successfully. So I don't know how quicker is compared with robotics, the training, because I have no experience about training or teaching residents in robotics. But what I can say is that uniportal is teachable, is doable, and the residents, when they spend time with us, or the fellows, go back and they do successfully. Of course, you need to spend time with them, you need to teach them, you need to advise them and let them to learn from videos, from textbook, from other things, not only do the web labs. I think it's a very useful way to learn, do the animal lab or the simulators. So it's different ways to learn, but it's doable.
You always use the same interface or access uniportal, or
Yeah.
or do you feel like sometimes during the operation you wish you were a little bit higher or lower?
Well, I will talk about this in my lecture. Normally, we can say that fifth intercostal space is standard intercostal space. You can do all the lobectomies through the fifth intercostal space. I only choose fourth intercostal space on the right side for upper lobes, but for the rest of the lobes, fifth intercostal space between anterior and middle axillary line. That's fine. You can do everything. You can have access to the posterior anatomy perfectly. So everything. There's no limitations in the cavity, in terms of view or access. Of course, I agree with the interpal about that. If you have multiple ports, you will have always better view, of course, because you have more angles to see. But I don't think that this is a need. I mean, I don't need more holes to have better view. Of course, if you have more holes, you have different angles. But I think it's not a need that it's a must. You need to have it. Because if you do the incision in the right place, not too anterior, not too posterior, you have access to everything you need to do into the chest. Lymph node dissection, lobectomy, segmentectomy, and of course you adapt the incision according where you are going. If you are going to do a bad splication, uniportal bad splication, you should be lower, maybe more lateral. If you want to do like a posterior resection of a mediastinal tumor, you should be more posterior, maybe lower, maybe upper, according to the location. So, but for lobectomy, a standard location, fifth intercostal space. And if you do it, you will never fail.
Venga?
Hi, Ben Gokasani, one of the junior faculty. This is really a question for Dr. Sarkaria and Dr. Lazaro. We're sort of in an interesting time where the early robotic adopters have sort of come up to speed. They're very prolific, and now we have these generations of trainees who are basically at these centers learning from these people and then have to go out to their various places. What are the common questions that you guys get called with by the people that you've trained who are good or great, and they go out and they call you and say, hey, I'm having this problem? What are the common technical issues or even logistical questions that they have for you sort of when they're done with you looking back as when they're in their early practice?
No, you call me every week.
That's true.
Great question.
You know, when you train someone, right, you can let them learn it the wrong way and then correct them, or you can just take them and teach them the right way from step one, so they get motor memory. And I think one of the things that, you know, it's not a month, because this isn't about teaching how to do a lobectomy. This is about how to really teach the robot, and it's a way more sophisticated instrument. So when it does go to uniportal, it's training on the robot to learn how to use it effortlessly so that you have an idea of proprioception, you have a visual haptic clue to the haptic sensation that you get. Biggest question we get is they don't pay attention to the arms and they get collisions. And then they're not willing to get up to the foot of the bed to see where the external collision is to fix it. So they get frustrated and they're like, you know, that operation was okay, but it took me a while. And you just got to get them past the fact that once the robot's in the right spot, you can do anything, because it's like having your hands inside. So for me, that's the biggest issue.
I think, and just to say, you know, Dr. Okasanya is someone I've had the real pleasure of mentoring through robotics as one of the Graham Fellows for the ATS and as a fellow, and now as an independent surgeon here with us. It's been fantastic to see the progression. I think your first month, Benga, your first 3 major cases were 3 anatomic segmentectomies on the robot, which you did independently. And I think is a real testament to the pathway that you went through. But I think my main advice is, the main question I get is, should I do this case robotically? And every surgeon, I think what Dr. Rivas said is very telling. Start with the single incision. See how far you can get. Keep it safe. Stay within your comfort zone. Maybe push your comfort zone a little bit. Keep the patient safe. Add the second and third port if you need it. Same with any concept, with any training paradigm. Do what you can, the way you intend to do it. Start robotically at some point. If it's just not working, put a VATS port in, convert to what you're used to. We're open. There's absolutely no medal for completing an operation one way. Uniportal, robotic, VATS. There's a definite medal for getting a patient safely through an operation with a good operation. And that's the key. Convert early. I'd like to see high conversion rates, not high, but relatively higher conversion rates early in a surgeon's experience, and then drop later. If you don't see those conversion rates, it sometimes makes you wonder if we're pushing things a little too far, a little bit unsafely. So that's my main caveat. Just take it at your own pace. There's no impetus to get to a full robotic lobectomy on your first day. It actually shouldn't be that way. Do it over the course of whatever your learning curve happens to be. We know more and more the learning curve is not 50. It's 100, it's 200, it's 300 to get to that level of mastery where you start to maybe push the envelope with certain things.
Yeah, I think it's a very important point, and and this is something that I always tell to my students, to my fellows, to the surgeons who come to especially to my training course in Shanghai. We have about 30 surgeons from all over the world every 2 months, 2 weeks with us there. And all of them are excited about the portal, because, you know, when you are in 2 weeks in a center that we do 80 lobectomies per day, 5 days a week, when you see this, everybody's excited to go back and start. I always say then, look, you should start with 1 incision, I agree, but never force, because for a uniportal, you need to learn a lot of things, a lot of tricks. We have only 1 hole, only 1 direction, only 1 chance, so you need to learn some tricks. And when you learn the tricks, they'll be fine. But at the beginning, the learning curve, I always say, maybe you will struggle with the upper lobe vein for the stapler, for the angle. So when you try to do this, and if you spend 5 minutes trying to pass the stapler and you cannot do it, don't force. Do the second hole, put a stapler, do the vein, and continue with uniportal. Because if you cannot do it, it's because you need more training. It's not because I never do the second port. So it's because it's not because it's not possible. It's because you don't know how to expose the lung to do it. So it's the worst thing you can do is, okay, I wanna do uniportal because I saw many surgeons in Shanghai Pulmonary Hospital doing uniportal. I had to do it. So if you are forcing the vein, maybe you have a bleeding, catastrophic bleeding, and then you will lose the confidence, and of course could be worse for the patient. So if after 5 minutes you cannot pass the stapler, what happened? I need to learn more. Second port, do the incision. If you need a third port, use a third port. As Inderpal mentioned, safety is the first. I'm not obsessed with to train people in uniportal. For me, the first is safety. So if I see a beginner that cannot pass the stapler, I say, don't worry. I teach him, but if he's alone in his hospital, I always say, don't force. Do the second port, do the vein, and then after 20 or 30 cases, you will learn how to do it. So this is always my recommendation. And if you need the third port, use the third port. It's not a failure. It's like, or convert a patient when it's bleeding. It's not a failure, never. If you have a bleeding and you don't know how to continue, the worst thing you can do is push, and wait, and then maybe do a late conversion when the patient lost more than 1 liter. So that is what you should learn, and this is a take-home message for the residents and for the surgeons in the learning curve. The worst thing you can do is to try to do it because, okay, I'm obsessed to finish in uniportal, or I'm obsessed to finish in BATS. Safety first, always.
Well, thank you very much. We're going to take a break, and we'll come back with our next session. Maybe just get up, stretch your legs, grab some coffee, and we'll start again in just a little bit.